Guided Tissue Regeneration, or GTR, is a revolutionary technique in periodontal therapy that focuses on regenerating the tissues lost due to periodontal disease. By using a barrier membrane, clinicians can selectively encourage the repopulation of periodontal ligament cells while excluding unwanted cell types like epithelium and gingival connective tissue from the defect area. This approach has transformed the way we manage periodontal defects, offering hope for restoring both function and aesthetics. In this video, we'll explore the principles, materials, indications, procedures, and advances in GTR, guiding you through each step of this fascinating regenerative process. The core principle behind guided tissue regeneration is the selective exclusion of certain cell types from the healing site. By placing a barrier membrane over the defect, the rapid migration of epithelial and gingival connective tissue cells is prevented. This allows slower-growing periodontal ligament cells to repopulate the area, leading to true regeneration of the periodontal attachment apparatus. This selective repopulation is crucial for achieving optimal healing and restoring the lost structures around the tooth. Barrier membranes used in GTR are classified into 3 generations. The first generation includes nonresorbable membranes, such as expanded polytetrafluoroethylene, EPTFE, Gore-Tex, dense PTFE, and others. These materials are designed to remain in place until manually removed. The second generation consists of resorbable membranes, which are gradually broken down by the body, eliminating the need for a second surgery. The third generation features resorbable bioactive membranes with added growth factors, further enhancing regenerative outcomes. Each type has unique properties and clinical applications. First-generation barrier membranes are non-resorbable, meaning they do not degrade in the body and must be removed surgically after healing. Common examples include expanded polytetrafluoroethylene, EPTFE, Gore-Tex, dense PTFE, nucleopore, millipore filters, ethyl cellulose, and semi-permeable silicone barriers. These materials are highly effective in maintaining space and excluding unwanted cells, but their main drawback is the need for a second surgical procedure to retrieve the membrane, which can increase patient discomfort and risk. Second-generation membranes are designed to be resorbed by the body over time, eliminating the need for a second surgery. These include collagen-based membranes like Biomed, Periogen, ParoGuide, TissueGuide, BioStite, BioGuide, and BioBar, as well as synthetic options like polylactide and polyglycolide, Guided, Vicryl, Atrisorb, Result, EpiGuide, Biofix. Other materials include periosteum, connective tissue grafts, alloderm, endogain, and various surgical sponges. These membranes offer improved patient comfort and acceptance. The third generation of barrier membranes incorporates bioactive components such as growth factors to further enhance tissue regeneration. These advanced membranes not only provide a physical barrier, but also actively stimulate cellular events that promote healing. EPTFE, one of the most inert materials, is often used due to its chemical stability and biocompatibility. The addition of growth factors represents a significant leap forward in regenerative dentistry, offering improved outcomes for complex cases. Expanded polytetrafluoroethylene, or EPTFE, is renowned for its chemical inertness and biocompatibility. Its structure features a long carbon chain protected by a dense sheath of fluorine atoms, making it highly resistant to chemical reactions within the body. As a result, tissues tend to accept EPTFE, exhibiting a healthy response without adverse reactions. This makes it a preferred material for non-resorbable barrier membranes in GTR procedures. Absorbable barrier membranes offer several advantages in guided tissue regeneration. Most notably, they do not require a second surgical procedure for removal, which greatly enhances patient acceptance and comfort. Surgical time is reduced, and the risk of losing regenerative tissue due to a second surgery is minimized. These benefits make absorbable membranes a popular choice in modern periodontal therapy. Despite their benefits, absorbable membranes also have some drawbacks. Proper manipulation and adaptation of the membrane against the roots can be challenging, and these materials often come at a higher cost. Additionally, clinicians have less control over the rate of biodegradation, and if infection occurs, retrieving the membrane can be difficult due to its disintegration at various stages. These factors must be considered when selecting a membrane for GTR. Guided tissue regeneration is indicated in specific periodontal defects where regeneration is feasible. These include narrow 2 or 3-wall infrabony defects, circumferential defects, class 2 furcation defects, and certain types of recession defects. Careful case selection is essential to maximize the chances of a successful regenerative outcome. Not all cases are suitable for guided tissue regeneration. Contraindications include medical conditions that preclude surgery, active infection at the defect site, poor oral hygiene, smoking, excessive tooth mobility, shallow defects, inadequate width or thickness of attached gingiva, short root trunks and furcations, generalized horizontal bone loss, advanced lesions with little support, and multiple defects. Proper patient assessment is key to avoiding complications. The surgical procedure for guided tissue regeneration begins with raising a full-thickness flap. This is achieved using vertical incisions that extend at least 2 teeth anteriorly and 1 tooth distally to the tooth being treated. This approach provides adequate access and visibility, ensuring that the defect area can be thoroughly debrided and prepared for membrane placement. After flap elevation, the next step is to thoroughly debride the osseous defect and plane the root surfaces. This ensures that all granulation tissue and bacterial deposits are removed, creating a clean environment for regeneration. Proper root surface preparation is critical for successful membrane adaptation and tissue healing. The barrier membrane is then trimmed to fit the size of the defect area. It should extend approximately 2 to 3 millimeters beyond the defect margins on all sides. This ensures complete coverage and effective exclusion of unwanted cell types, setting the stage for optimal regeneration. Once the membrane is properly trimmed, it is sutured around the tooth using a sling suture technique. This method secures the membrane in place, preventing displacement during healing. Proper stabilization is essential for maintaining the regenerative space and ensuring successful outcomes. The final step involves repositioning the flap to its original or slightly coronal position and suturing it with interrupted sutures. It's crucial to ensure that the membrane is completely covered by the flap. For nonresorbable membranes, removal is required after about 5 weeks, using a gentle tug to retrieve the material. A key aspect of GTR is the stabilization of the fibrin clot at the root surface. This clot acts as a barrier, preventing the apical migration of the gingival epithelium and allowing connective tissue attachment during early wound healing. Proper clot stabilization is essential for successful regeneration and long-term periodontal health. The outcome of guided tissue regeneration is influenced by a variety of factors, both barrier-independent and barrier-dependent. Patient-related factors, defect characteristics, and surgical techniques all play a role, as do the properties and handling of the barrier membrane itself. Understanding these variables is crucial for optimizing regenerative outcomes. Barrier-independent factors include patient-related variables such as plaque control, smoking, and stress. Defect-related factors like the type of defect, tooth mobility, and gingival thickness also impact healing. Additionally, surgical techniques, including flap elevation and closure, can influence the regenerative process. Addressing these factors is essential for achieving predictable results. Barrier-dependent factors relate to the membrane itself and its handling. Inadequate adaptation to the root, non-sterile technique, instability of the barrier, premature exposure to the oral environment, and early loss of the membrane can all compromise regeneration. Proper membrane selection and meticulous surgical technique are vital for success. According to Kornman and Robertson, the primary factors affecting clinical outcomes in periodontal surgery include bacterial contamination, innate wound healing potential, local site characteristics, and the surgical procedure itself. Each of these elements must be carefully managed to maximize the likelihood of successful tissue regeneration. The PASS principle, introduced by Homley Wang and Boyapati, outlines 4 critical factors for successful regeneration: primary wound closure, angiogenesis, space maintenance, and stability. Ensuring these elements are addressed during surgery can significantly improve regenerative outcomes and patient satisfaction. Root biomodification is an important adjunct in GTR. Citric acid, when applied at pH 1 for 2 to 3 minutes after root planing, demineralizes the surface and exposes collagen fibers. This promotes cementogenesis and the attachment of collagen fibers, accelerating healing and preventing apical migration of the epithelium. Citric acid also helps remove the smear layer and residual calculus, disinfecting the root surface. The steps for root biomodification with citric acid are straightforward. First, a full thickness flap is raised, followed by thorough root planing. Cotton pellets soaked in citric acid pH 1 are applied to the root surface for 2 to 3 minutes. The area is then irrigated with water and the flap is replaced and sutured. This process enhances the regenerative environment and supports tissue attachment. Growth factors are polypeptide molecules released by cells in the inflamed area, playing a key role in regulating wound healing events. Secreted by macrophages, endothelial cells, fibroblasts, and platelets. These factors include platelet-derived growth factor, insulin-like growth factor, fibroblast growth factor, and transforming growth factors alpha and beta. They promote fibroblast proliferation and bone formation, supporting periodontal regeneration. Enamel matrix proteins, particularly amylogenin, are secreted by Hertwig's epithelial root sheath during tooth development and can induce acellular cementum formation. Products like Emdogain, derived from porcine teeth, mimic natural developmental processes and have been approved for clinical use to promote periodontal regeneration. Biologic modifiers are materials, proteins, or factors that have the potential to alter host tissue and stimulate or regulate the wound healing process. They can act systemically or locally, promoting various cellular interactions such as migration, attachment, proliferation, differentiation, and matrix synthesis. Their use is expanding the possibilities in periodontal regeneration. Biologic modifiers play a pivotal role in promoting the regeneration of periodontal tissues. By facilitating cell migration, attachment, proliferation, differentiation, and matrix synthesis, these agents create a favorable environment for tissue repair and regeneration. Their application can significantly enhance the outcomes of GTR procedures. Platelet derivatives, such as platelet-rich plasma, PRP, platelet-rich fibrin, PRF, platelet-rich fibrin matrix, and plasma-rich growth factors, are increasingly used in periodontal regeneration. These products are rich in growth factors that accelerate healing and support the formation of new tissue, making them valuable adjuncts in GTR. Growth and differentiation factors are essential for orchestrating the complex process of tissue regeneration. Platelet-derived growth factor, PDGF, insulin-like growth factor, IGF-1, transforming growth factor beta, TGF-beta, fibroblast growth factor, FGF2, and vascular endothelial growth factor, VEGF, all play unique roles in promoting cell proliferation, angiogenesis, and bone formation. Bone morphogenic proteins, BMPs, are a unique group within the TGF-beta superfamily, playing a pivotal role in bone induction, maintenance, and repair. The human genome encodes at least 20 BMPs, with BMP 2, 3, 4, 6, 7, and 12 being particularly important in bone healing. These proteins are integral to successful periodontal regeneration. Enamel matrix derivatives, mainly amylogenin, are proteins secreted during tooth development that induce a cellular cementum formation. Their application in periodontal regeneration mimics natural developmental events, promoting the restoration of lost tissues. These derivatives are delivered as a viscous gel and have been approved for clinical use. Extracellular matrix derivatives such as fibronectin, vitronectin, thrombospondin, and amylogenin play important roles in cell adhesion, migration, and differentiation. These proteins contribute to the regenerative process by supporting the attachment and proliferation of cells at the defect site. Peptides, like thrombin peptide, TP508, and cell binding P15, as well as small molecules such as prostaglandin, E2, receptor antagonists, are being explored for their regenerative potential. These agents can modulate cellular responses and enhance the healing process, offering new avenues for periodontal therapy. Tissue engineering in periodontal regeneration involves three main approaches: protein-based, cell-based, and gene-based techniques. These strategies aim to reconstruct lost tissues by combining scaffolds, signaling molecules, and cells, creating an environment conducive to regeneration. The scaffold provides a three-dimensional framework for cell attachment and tissue development. It must be biocompatible, support cell migration, and allow for the diffusion of nutrients and waste. The choice of scaffold material is critical for the success of tissue engineering strategies in periodontal regeneration. Signaling molecules, including growth factors and cytokines, orchestrate the complex interactions required for tissue regeneration. They guide cell migration, proliferation, and differentiation, ensuring that the regenerative process proceeds in a controlled and effective manner. Cells are the building blocks of tissue regeneration. In periodontal therapy, various cell types, including stem cells, fibroblasts, and osteoblasts, are used to repopulate the defect area. These cells interact with scaffolds and signaling molecules to form new tissue and restore function. Protein-based tissue engineering approaches utilize bioactive proteins, such as growth factors and extracellular matrix proteins, to stimulate cell behavior and promote regeneration. These proteins can be delivered directly to the defect site or incorporated into scaffolds for sustained release. Cell-based approaches involve the transplantation of living cells into the defect area. These cells can be harvested from the patient or obtained from other sources, then expanded and delivered to the site to promote tissue regeneration. This strategy holds great promise for personalized periodontal therapy. Gene-based tissue engineering introduces genetic material into cells to enhance their regenerative potential. By delivering specific genes that encode for growth factors or other bioactive molecules, clinicians can stimulate targeted tissue regeneration. This cutting-edge approach is still under investigation, but offers exciting possibilities for the future. Guided tissue regeneration represents a significant advancement in periodontal therapy, offering the potential to restore lost tissues and improve patient outcomes. By understanding the principles, materials, indications, and techniques involved, clinicians can select the most appropriate approach for each case and maximize the chances of success. The field of guided tissue regeneration continues to evolve, with ongoing research into new materials, biologic modifiers, and tissue engineering strategies. Advances in stem cell therapy, gene editing, and bioactive scaffolds hold promise for even more effective and predictable regenerative outcomes in the future. Successful guided tissue regeneration requires careful patient selection, meticulous surgical technique, and appropriate material choice. Clinicians must also manage patient expectations and provide thorough post-operative care to ensure optimal healing and long-term stability of the regenerated tissues. In conclusion, guided tissue regeneration is a cornerstone of modern periodontal therapy, offering the possibility of restoring lost structures and improving oral health. With ongoing advancements in materials and techniques, the future of periodontal regeneration looks brighter than ever. Thank you for joining us on this journey through the science and art of guided tissue regeneration.